Hello and welcome everyone. Today we will be discussing about the brainstem dysfunction in ICU. The brainstem is located at the lower part of the brains, connecting the diencephalon, a part of the forebrain, to the spinal cord and the cerebellum. It bridges the sensory and the motor pathways between the brain and the spinal cord. Understanding the brainstem function helps in managing conditions in ICU like stroke patients with sudden breathing difficulties, critical illness causing altered sensorium and consciousness levels. So, coming first to the functional neuroanatomy of the brainstem. The brainstem is divided into three main parts: the midbrain, the uppermost section connected to the diencephalon, pons, the middle section serving as the bridge between midbrain and the medulla, medulla oblongata, this is the lowest section connecting to the spinal cord. This is the diagrammatic representation of the brainstem. So the composition of the brainstem is composed of gray matters and the white matters. So in the gray matter, it has cranial nerve nuclei. So you can see the cranial nerve nuclei which are present in the anterior location. This is the anterior, this side. This is the superior. This is the right. This is up. So you can see the various cranial nerve nuclei which have been shown here in the anterior surface. And you also have motor functioning cranial nerves for eye movement and swallowing. You have the ascending reticular activating system, the ARAS, which is in the posterior segment, which maintains the arousal and wakefulness. Extrapyramidal system which controls the autonomic movements like posture and locomotion. So you also have the central autonomic nervous system which manages vital functions such as heart rate and digestion. In the white matter, these are all the gray matters that you see. In the white matter, you will find the ascending sensory pathways which carry the sensory information. We will see this in the next diagram. We have the descending pathways, the pyramidal tracts which control the voluntary movement, the extrapyramidal which control the automatic and the involuntary movements. So here you can see the various tracts or the white matters that we saw right now. These are the various tracts and the nuclei. Here you can see the nuclei and the tracts are seen over here. So this is just a table summarizing the various tracts and their functions. So the vascular supply of this region is coming from the basilar artery, which is the primary blood supply. So the function of the brainstem for the white matter is brainstem reflexes, that you have the gag reflex and the pupillary reflex, arousal, keeping us awake and alert, homeostasis, maintaining a stable internal condition by the autonomic nervous system, that is controlling the blood pressure and the breathing. In the white matter, the sensory pathways relay the signals of the pain and temperature to the brain. Motor pathway transmit the commands from the brain to the muscle. So this is grossly the functional anatomy that we need to know as intensivists. Now, when to suspect that there is a brainstem involvement? Sensory or motor deficits combined with cranial nerve paralysis, impairment of consciousness, that is patient is having drowsiness, coma, dysautonomia, that is disruption in the autonomic function like increased heart rate or bradycardia or changes in the blood pressure, neurological respiratory failure, inability to breathe due to brainstem dysfunction, or tachypneic patients without any pathology in the lungs. So motor and sensory deficit in the brainstem lesions is mainly because of pyramidal and extrapyramidal tract involvement. The pyramidal tracts, as we already know, they control the voluntary functions, they control our limbs. The extrapyramidal tracts, they manage our reflexes, complex movements, and our posture, basically the involuntary ones. The upper motor neuron damage can result in hemiparesis, which we see commonly in strokes, that is weakness of one side. Locked-in syndrome is a complicated thing where you get complete paralysis except for the vertical eye movement, which is preserved with preserved consciousness, which is caused by bilateral pontine lesions. Now, the only way by which we can know that the patient is having a consciousness is the patient will obey a command and do the vertical eye movements on our request. Now, the clinical features, the ipsilateral cranial nerve palsies or cerebellar signs, same side as the lesion, contralateral motor deficit, that is on the opposite side of the body. Examples of abnormal movement like hemichoria, hemibolism, dystonia, tremors, asterexis, pseudoathetosis, and myoclonus can be seen. Regarding the cranial involvement and the reflexes, damage to the cranial nerves can cause dysphagia, difficulty in swallowing, dysphonia, hoarseness or difficulty in speaking, pseudobulbar effects, that is uncontrolled laughing, crying, emotional instability. Sensory deficits here can come like contralateral proprioceptives or touch loss, contralateral pain or temperature loss. Eye signs, abnormal eye position and movement indicate brainstem involvements, pupillary changes. That is, third nerve lesion can result in a dilated pupil. Horner syndrome, that is meiosis, drooping eyelids and shrunken eyeball, and lack of sweating. Key reflexes to assess in critical care. So now that we know something about the functions of the brainstem, let's see what are the tests which we can do at the bedside in critical care to know that the patient is having some brainstem lesion. You can check the pupillary reflex, you can check the corneal reflex, oculocephalic reflex, that is eye movement in response to the head rotation, gag reflex, swallowing reflex when back of the throat is touched. Special tests can be done like oculovestibular reflex and primitive reflexes, which are rarely relevant for the ICU settings. Advanced tools like automated papillometry can be used, which provide precise measurement of the pupillary response. Diagnostic tool for brainstem lesions, we have MRI, which is the best method to localize and characterize a lesion. Evoke potential, which detects disruption in our sensory and motor pathways. EEG, which is helpful for abnormal movements and altered sensoriums. CSF analysis, which helps in finding out inflammatory and infectious causes. Clinical application. Always consider brainstem pathology in unexplained combination of motor and sensory deficit with cranial nerve abnormalities. Example is a patient with hemiparesis with swallowing difficulty may have a brainstem lesion. Now, reflex assessment are essential for determining the brain death in critical care setting as well. So the role of ARAS in consciousness is important because we get frequently these patients with low consciousness, altered sensorium, which are drowsy most of the time. So the ARAS in the midbrain and the pons regulate our sleep-wake cycle. They include nuclei like the locus ceruleus, thalamus, and pedunculopontine nucleus. The key pathways over here are the monoaminogenic neurons, which connect to the cortex and inhibit the deep sleep. Cholinergic nuclei, which is active during rapid eye movement sleep, indirectly linked to cortex via the thalamus. Now, the type of consciousness disorder that we can see, some are acute, that is coma. You see state of unresponsiveness with closed eyes, cannot respond even to strong stimuli. Brain death, which is the absence of all reflexes and irreversible loss of the brain function. Delirium, more common, which is acute fluctuating disturbance in the consciousness with impaired attention. This can lead to long-term cognitive issues with ICU survivors. Clouding of consciousness, that is reduced clarity of awareness, less commonly used for brainstem lesions. Stupor, minimal but present response to strong stimuli. Now, you can get chronic and subacute presentations like vegetative state, that is spontaneous eye opening without any awareness. Minimally conscious state, that is minimal awareness with intermittent non-reflexive responses. That is, they do follow command, but then not always. Both the vegetative state and the minimal conscious involve preservation of the ARAS because the patient is awake. But there is impairment of the higher brain networks, that is, the cortical functions are little impaired. So, brainstem dysfunction features are cognitive deficits like impaired attention, memory, executive functions, hallucinations seen with lesions in the peduncular lesions, and the assessment of consciousness becomes most important. So how do we assess consciousness? The most common way is GCS. It is a standard tool. You can use the 4 score also, which is considered to be more advanced and more better assessment of consciousness level than GCS. And you use the sedation scoring, that is the RASH, Richmond agitation sedation scale, which assesses the sedation depth. You have the brainstem reflex assessment sedation scale, the BRAS. This is the table of the BRAS. You check for the absence of cough reflex, pupillary, corneal, grimacing to pain, and absent of the oculocephalic reflex, and absence of grimacing and pain and presence of oculocephalic is 3. So based on this scoring, you find out what is the brainstem reflex. We have other diagnostic tools, as we have already seen, that is MRI, neurophysiological tests like somatosensory evok potentials, which measure the conduction of the nerve to the brainstem and the cortex. You also have the brainstem auditory evok potential, that is BAEP, which assesses the auditory nerve and the brainstem pathways, and it predicts outcome in trauma brain injury actually. EEG reactivity, that is absence of response to stimuli, indicates poor prognosis. Prognostic insights you can get with BAEP, where a preserved BAEP after traumatic injury suggests good outcomes. Absent response indicates that injury to the auditory nerve or there is presence of some kind of hypoxic brain damage. EEG reactivity is again important. A lack of response indicates ARAS or thalamic brainstem dysfunction, often linked with poor outcomes. Treatment and interventions that we can do. You can stimulate the ARAS with techniques like vagal nerve stimulation, deep brain stimulation, which has shown promise in improving consciousness levels in the vegetative states and minimally conscious states. You can go for sedation effects, that is sedatives affect the evoked potential, especially at high dosages. Clinical application is, say for example, in a comatose patient with absent brainstem reflex, focusing on MRI and evoked potential studies to confirm our diagnosis and prognosis. Reflexes like pupillary reflex and corneal reflex are critical in assessing uncal herniation and brain death. Regarding the autonomic nervous system, it can also get affected. The components are the sympathetic, which originates from the spinal cord D1, D3, and it affects the increased heart rate and blood pressure and pupillary dilatation. Parasympathetic is which is originating from the cranial nerves and the sacral outflow. It affects the decrease in heart rate BP and increased GI activity, bladder contraction, pupillary meiosis. A clinical relevance of ANS dysfunction is that brainstem region will disrupt the ANS, resulting in cardiac arrhythmias common with brainstem strokes, which is again linked with high mortality. Adrenergic storm because loss of the parasympathetic activity. Brain death, presence of loss of the vasomotor tone and reduced heart function. Diagnostic methods that we use are the heart rate variability, high frequency reflects parasympathetic tone, and low frequency reflects sympathetic tone. So we make a ratio, a good balance indicates that all the systems are going okay. You can do pupillometry, which detects or dysautonomia through resting pupil dilatation and slowed redilatation times. Regarding neurogenic respiratory failure, the respiratory muscle control is coming from the dilator muscles, that is the upper respiratory tract muscles, which is by the cranial nerve 5, 7, and 12. Pump, that is the diaphragm and intercostal, which is coming from the spinal motor neurons via the autonomic pathways from the brainstem, and voluntary pathway from the corticospinal tract. Regarding the brainstem and the respiratory drive, it is controlled from the medulla. You have the inspiratory and the expiratory center adjusted based on the inputs which are coming from the respiratory signals. So you also have modulators like metabolic signals, the chemoreceptors which detect the CO2 and O2 levels, mechanical signals, that is mechanoreceptors, which detect the stretching of the lungs and the airway. The pattern of dysfunction: midbrain lesions rarely affect respiratory rate. Upper pons lesions increase tidal volume, decrease respiratory rate. Lower pons lesion cause respiratory asynchrony. Medulla lesions cause ataxic breathing, central apnea or hyperventilation, yawning and hiccups. Structural and non-structural causes such as infratemporal lesion, drug toxicity, sepsis, and heart failure. Clinical features being swallowing impairment, complicated weaning from ventilator, and may require a tracheostomy. So regarding the assessment and diagnosis, the basic respiratory monitoring, that is tidal volume, RR, and ventilator curves are to be monitored. Assess the response to hypercapnia during trials, that is TP's trial. Advanced diagnostics like EMG, measuring diaphragm's activity, can be done. Spirometry and occlusion time, that is P0.1, which will indicate your respiratory drive. Practical application of this is that in mechanically ventilated patients, monitoring the ventilator curves for irregular patterns is important. Consider EMG if prolonged weaning difficulties is occurring. Use papillometry to assess the ANS dysfunction. Be aware of structural causes like brainstem strokes and lesions within the respiratory tract for the patterns to become abnormal. Brainstem dysfunction in critically ill patients is depicted to us by clinical features like the common causes being primary brainstem dysfunction, which is seen in stroke, trauma, infections; secondary dysfunction, which is seen in critical illness related to secondary insults, prolonged deep sedations, systemic inflammations. The impact of sedation is important because sedatives like midazolam, fentanyl, and opioids often spare reflexes like pupillary light, corneal, and cuff reflexes, and depress responses such as oculocephalic reflex and grimacing. So there are various causes of acute brain dysfunction. That is, you can have vascular causes, inflammatory causes, traumatic, metabolic, infectious, paraneoplastic, and in chronic you can have tumoral or degenerative atrophies. Regarding the pattern of reflex sedation, the pattern 1 is that there is a generalized loss of all brainstem reflexes. While it's in pattern 2, there is selective loss of pupillary reflex, corneal and cuff reflex with preservation of oculocephalic reflex. The key tools for assessment over here are the BRASS score that we have already seen and the 4 score. Regarding the electrophysiologic, autonomic and respiratory features, neurophysiological testing, the EEG non-reactivity 25% in septic patients suggests that there is a ARAS dysfunction. We can use the electrophysiological test which indicate latencies in 24 to 45% in deeply sedated ICU patients, indicating impaired brainstem conduction. Autonomic changes, which is by the heart rate and BP variability, impaired baroreflex and sympathetic tone, reduced tidal volumes. Respiratory features, you can find caudal lesions impairing autonomic respiratory control, leading to an ataxic type of breathing, and central apnea. Structural causes and systemic causes contribute to these dysfunctions. The mechanism of brainstem dysfunction is that can be vascular insult, inflammatory, as we have already seen, metabolic. Regarding the neuroinflammatory pathways, the humoral pathway, the inflammatory mediators enter the brainstem through the area proxima. The neural pathway, the vagal nerve transmits the peripheral inflammatory signals into the brainstem. These pathways influence the autonomic nuclei and regulate the systemic inflammation. Clinical implications of this is that for assessment, you check the brainstem reflexes, that is BRASS and 4 score. Multimodal evaluation, use EEG, SSEP, BAEP. Prognostic insights you will get from the persistent reflex abnormalities, increased evoke potential latencies, reduced variability in your autonomic and respiratory signals. Mechanism of the damage we have already discussed. Regarding research and future direction, multicentric study like the PRO-RECPRO aims to standardize multimodal assessment techniques for brainstem dysfunction in critically ill patients. So finally, ending with what are the potential differential diagnoses we can have for brainstem reflexes. You can go through this table. You will see all the reasons that are given over here. Thank you for your patience.